My name is Priscila. I'm a senior research scientist at Renal Research, and here with me, well, of course the panelist, but here with me to moderate this session is Raja Dandamudi.
Yes.
I said it correctly. He is the winner this year for the abstract. He's going to present tomorrow. And today we're just going to have a nice and coffee discussion about how failures and successes shape professional life. And we have our amazing panelists here. So they really don't need introduction, but they do because I have to. And we're just going to have a nice talk on what makes them who they are right now, what keeps them going, what keeps them motivated. And of course, I want to welcome you all, so you can go to the app, you can put questions there. They're anonymous, so you can just ask whatever you want. I'm not going to mention any names. And I was talking to Dr. McIntyre, and he says, can we be honest? And I said, yes, please, so be honest, no sugarcoating on your answers, so you can say exactly what you think. And of course, for introduction, I'm going to start with the women because I'm a woman too. So we have Magdalena Madero. She's the head of the department, the nephrology department in the National Heart Institute in Mexico. I'm from Mexico, so I'm really fond of her. She's kind of my idol. It's Allison Tong. She is a professor. She's a professor at School of Public Health in the University of Sydney, Australia. She has a lot of publications. She's a co-founder and part of the executive committee of the Tong initiative. And she has multiple awards for her work in research. Of course, we have Thomas Golper at the corner there. He's also an accomplished nephrologist. He's currently a professor of medicine and the medical director of the home dialysis program at Vanderbilt University Medical Center. He led the Network 9 peritonitis and catheter survival study and has over 200 articles and publications and chapters. So again, another truly accomplished physician. Of course, we know and we heard McIntyre, Dr. Christopher McIntyre, this morning in this amazing research that he's done. He was trained in the UK. He was a professor in Nottingham University, and then he relocated to Canada in 2014, and he's currently the professor of medicine, pediatrics, and medical biophysics there. And lastly, we have John Daugirdas. We know who he is. He was recognized by FASN in 2018 by the Belden Scribner Award for his outstanding contributions to the nephrology field and their impact on the care of patients with kidney disease. So you're a legend. And so and I don't know if you want to say something at this point.
Please feel to question the moderator panelists, and we'll get some answers. Please use the app and put on the questions.
Okay, we're going to have a seat because it's going to be long. So I want to start, I'm a romantic, so I want to start with really simple questions that I think everyone probably heard when they're initiating or beginning this research or med school or nephrology. So why nephrology? Why did you pick nephrology? Research, I will say the nephrology residency or going into research in nephrology or teaching nephrology. And if you have to do it again, will you pick again nephrology? And I will start with the woman. So Magdalena, if you could.
Well, that's a good question. I was about to be a cardiologist. I was already accepted in the program to be a cardiologist. My dream was to be an interventional cardiologist. But one of my role models was Dr. Jim Strom, an amazing clinician and nephrologist in Boston. And he actually tried to convince me to go into nephrology. And I thought about it for a while. And then I decided that, well, if there's kidney transplantation and there's hemodialysis and there's acid base and electrolytes, then you have an amazing field. So that's when I decided that I wanted to do nephrology. However, it was very competitive at the time, not as it is today, unfortunately. So we were fighting for one only position between 4 residents of internal medicine, and I have to say that that was one of the toughest things. But anyway, I got chosen, so I felt honored to start my fellowship at Tufts, and I would do it again without a doubt. I'm in love with the specialty. I think it offers so many things. I think you can think through disease. It's integral. You see everything. You never forget about internal medicine. So definitely, I would do it again.
Yeah. Dr. Daugirdas, will you pick nephrology again if you had to?
Yeah, definitely. I mean, for me, I loved all parts of medicine. In fact, I started out my career in surgery, and I did an internship in surgery in Boston University, and then second-year residency at McGill. And then I was thinking of going on to orthopedics, perhaps. And it just seemed that I remember I was on the cardiovascular surgical service, and we had gotten up at 4:30 in the morning, and we had seen about rounded on 70 patients, and then we had our first case at 7 in the morning. And then at 9:30, the first case was over, and we were going to the ward to change dressings. And then I saw the internists coming in with their pipes and their coffee, and I said, okay, this is what I want. I don't want the cardiovascular surgery or the surgical life. So then it was difficult, because when you change from one area of medicine to another, people think that you don't know what you're doing. So I actually had problems getting accepted into an internal medical residency program. And then there's always a gap, because you always have to apply well in ahead. So I worked for 2 years in emergency rooms, and then I wound up in a very interesting program in Chicago that was one of the few standalone programs that the Veterans Administration had, called VA Hines. And there I sort of fell into and was very influenced by the chief of nephrology there, Dr. Todd Ng, who convinced me to be into nephrology. I remember going on talking about cardiology rounds, cardiology service, and we would go around on 40 patients, and I'd say, oh, what's your problem? I have shortness of breath. Then I'd go to the next guy, what's your problem? Oh, I have chest pain. Then the third guy, what's your problem? Oh, I have a shortness of breath. And then we had 45 patients, and they all have shortness of breath or chest pain. I couldn't keep them all straight. And I said, no, this has to be something more interesting in life than shortness of breath and chest pain. And then this, coupled by Dr. Ng, just was a very sort of original sort of thinker, and dialysis was just getting started. And as Magdalena said, there's so many dimensions to nephrology. It's a 7-dimensional field, whereas most of the other specialties are 1-dimensional. And you sort of have to be good or interested in many things. And so I think that's what makes it so challenging. And, of course, the financial issues aside, I do think it's one of the premier specialties of internal medicine.
Yeah, I think I'm also a nephrologist, and when I did my residency, now that you're talking about when we're switching and then when we're going to rounds, I was an internal medicine resident, and one of my patients had to go to surgery for just a note. So the doctor said, you want to come in? And I'm, not really. Like, why? It's just surgery. I don't do that. And I said, well, yes, I'll go because it's my patient. So, and then he took out the note, and then he was like, do you want to close? What? Yeah, close. Because like it's just like the fun part of surgery and stuff like that. And I'm like, no, I'm an internal medicine. I like being out like at my floor with all the patients are just like saying that we don't do anything because we don't do surgery. And that's one of the things that I also remember, like when choosing, I chose internal medicine and then I went into nephrology, and I never had, it's just funny to hear that you went into surgery and completely dramatic change into orthopedics and then going to internal medicine because you saw people like with coffee, so I want to do that, exactly what happened to me. I want to ask you, do you, Dr. Thomas, do you think that nephrology has changed over when you were a resident, when you were a fellow? Do you consider that it has changed and evolved over the last years for the new fellows that we have here?
Evolved, yes. Changed, yes. Some to the better, some to the worse. The part that is to the better is the science. We have incredible scientists, as witnessed up here. To the worse is we have devices and toys that can keep people alive when that isn't always the smartest plan. And I think the challenge for our profession is to find that balance. I'll leave it at that. As John pointed out, the cardiologist and the cardiovascular surgeons, at least at our institution, if a new VAD or a new VAD-like device is available, they're going to try it. And this is a patient that has a 99.9% chance of mortality, and they want to try their device, and they're going to ask us to do CRRT so they can try their device. And so I think the challenge for the next generation of nephrologists is to say, let's do the right thing. Let's take the big view of it. Science needs to go forward. We need to study devices, but we need to look at the human side of what we're doing in medicine. And I fear for nephrology because I want the youngsters to have the courage to say, wait a minute, that's not the right thing to do.
Okay, thank you. Allison, I want to talk to you, ask you a little bit about your challenge. You're not a physician, you're a researcher, and you're focused on kidney care, patient-oriented. So what was your biggest challenge when you started your career as a researcher in this field?
That's quite a nice segue following on from Dr. Golper, because when I first started out in this research, it was probably 15 years ago, and I commenced a PhD looking at patient priorities, perspectives, the experiences of living with chronic kidney disease. And just going back to your first question, to be honest, I actually wanted to do research in childhood cancer, but no one wanted to work with me. So I sent an email out to the faculty, and I had a few responses, drug and alcohol. But the most obscure one to me was on a topic, it was a Cochrane review on anti-infective agents for preventing peritonitis and peritoneal dialysis. So when I was doing that Cochrane review, I became more interested in how patients actually cope with doing dialysis, how they cope with living with chronic kidney disease, and realised there's actually very little research in this area. And that's when I kind of embarked on this PhD to look at that topic. And when I first started out, I have to be honest, I think I faced quite a lot of skepticism, resistance from the nephrology community. I think because it was a new area, qualitative research, it was kind of a new method that doesn't get covered in medical school, medical training, and people were saying, implying things like, well, qualitative research, how's your work, scientific? It's kind of airy-fairy. How do we know that you're not just making it all up? So I did face a little bit of resistance there, but through perseverance and I think through really a strong mentorship, so Jonathan Craig was one of my mentors, seeing now over the past kind of decade and a half, and now how patient-centered outcomes, partnership with patients, understanding patient-centered outcomes, it's now embedded in policy, in kind of funding agencies, regulatory agencies. So I've seen a really amazing shift over the past year. So I guess the key point is just to persevere with what you're doing.
Yeah. Thank you. Dr. McIntyre, this is really, and I was talking to Peter before, and then he's like, you need to be bold and ask like really hard questions. So, and he mentioned something like, what do you think or you consider your biggest fail in your professional career, if you consider that you have?
I'm still really hopeful it's still ahead of me. And I'm still working towards that really enormous stinking failure. Biggest failure. it's,
Not sure.
That's what they ask in all the medical school applications now.
Yeah.
it is.
What was it?
Chris, she means professionally.
Yeah.
Oh, and obviously, the others are all very obvious. It's hard to fail when you don't have a plan. And we were talking earlier, and Tom's quite right, that so much of all of this is luck and happenstance. And it's a question of just making the best opportunity use when you get these opportunities. Like all of us, I didn't want to be a nephrologist. I was going to be an intensivist. I trained in medicine. I had a fellowship in anesthetic coming up. I had a 6-month gap. And I went to, I thought, 6 months nephrology, that'll be useful. I rolled up at the interview and there were 17 other people there for one job. And I thought, this is not good. So I'm being interviewed, and this is 1992. Everybody wanted to do T cells. And so I was being interviewed by Tony Rain, who's the professor of nephrology at Barts, and he said, are you an immunologist or a physiologist? And I sat there, I sort of looked out at the other 17 people, and I thought, I'm going to have to say something different. So I said, my mother always taught me, if you can't measure it in millimeters of mercury, it's not real. And by sheer dumb luck, it turned out that he also was a physiologist. So from that point on, having faked it to make it, I sort of had to try and pretend to keep carrying on. I think I like to build things, and I think my biggest regret was needing to move country to be able to build what I wanted.
Okay.
Because of local factors, funding, attitudes, etc. I'd got to the point where I was in the UK, we couldn't really take the mission any further. Now, I don't regret having done it, but I regret the need to do it. Because you have to put a lot of people through a lot of stuff, and it's very self-centered. You know, other people have to move countries and jobs, and people who are planning to do things can't. So I think it's okay to be a dick once in a while. You just can't make a career out of it.
Okay, that's really good to know. And now that you mentioned, like, sometimes relocation and like all this stuff, I was talking to Dr. Madero before, and she emailed me and said, I think one of your biggest challenge was you were trained in the US, you did your residency in Boston, and then you went back to Mexico and practiced in Mexico. How was that for you? Because we have a lot of fellows here that are from Mexico, from Latin America, from the US, we have a diverse, and then we have students, we have PhD students, master students, so we have a lot of, a big kind of crowd. So I asked you that because I also graduated in Mexico, and then I'm here, and that it's been a challenge for me. So how was that for you?
Well, I could say that was the biggest failure and the biggest success of my career at the same time. So I did internal medicine and nephrology in Boston, and my husband did his business school in Harvard, but he was done like 6 years before me. So he stayed over working. He got a job in New Hampshire, so he commuted every day. And by the time I was done with nephrology, I was ready to stay. I already had a faculty position. I was very honored to have had that opportunity. They worked out my visa issues. And my husband said, well, you know, I've been waiting for 6 years, you know, we're going to go back home. And I wasn't ready, so that was very tough. When I left Tufts, I thought what I thought were the greatest letters of recommendation that anyone could get. I got home and I knew I wanted to do academic medicine, so there were only a few options for me in Mexico City, actually a couple. One is where I am, and the other one was nutrición. So there was a lot of closed doors for me. Actually, I came back to nutrición and they said, well, we would love to have you, but we have no positions. This is what they tell everyone. Even worse, at cardiology, where I'm now, the former chief said, well, we have no positions, nor we're interested. And, you know, before you, we have 3 or 4 people waiting for a position. So there's a long line, and there's no way you can get in here. So I got back home crying. I'm like, I already had my life and my career were all set in Boston, and here, they're not even opening a door. I thought they not even read their recommendation letters. They just trashed them away. And so I had to go back to the hospital director and said, seriously? I mean, is this real? Like, no one's going to open a door. So he had a little bit of more vision, and he said, well, you should stay with no position, with no office, but let's give it a try. So they were paying me $250 a month to do what my dream was.
You can't even buy a shoe. Okay.
Yeah, and I didn't have an office, so I was sharing an office with the head of the hemodiafiltration unit. After like 3 months of being there, I'm like, I cannot take it anymore. So I actually took my desk and put it in the hall. So this is where I was. I rounded in the hall, like, had no position. And then things changed. But the thing is, to me, the learning point is it doesn't really matter, who recommends you. Like, you have to start from scratch. This is what happened to me. You have to prove who you are. You have to be determined. And, nobody really cares if in other area you were wonderful. You need to prove yourself and start from scratch. And, I can tell you that as of today, it took me 10 years. I had an offer to go back to Boston. I interviewed at the University of Colorado. I got in a position in there. And I can tell you that as, more than 10 years of coming back, this was the best decision. And I think staying in the US, I would have been one nephrologist more. And I think the impact that I've had in my country is much more significant. So, but it was very tough.
That's a really nice story, because I think one of the things that we encounter when we're going to start our careers, and then we think that, it happens to me, or when you finish school, that's like, oh, I'm done. And then you realize, oh no, I'm just starting. Actually, when you finish residency, when you finish your PhD, when you finish your education, you're just starting your career, your professional development. And then we have this idea that everything we've done during the education part is the difficult part. And I'm, like you said, the young nephrologist. I consider myself a young nephrologist, and I'm still wondering sometimes what is the next step, and I keep growing every time, and it's really, I motivate myself just to listen to this. And one of the things you just mentioned is that your husband was there with you. So, and then you have to go back because he wanted to go back. So I was talking to Dr. Golper about that, and not about your husband, of course, but how do we manage and how do we blend or cope with personal life and professional career? How do we determine which one is the best, or if we go this way but we sacrifice a little bit of the personal life, or how do you manage to balance this, Dr. Golper?
There was a famous quote by Jill Ruckelshaus, and she said, the best way to win an argument is to start out by being correct. And I was lucky enough to marry a woman who has helped me through my career, and we've made sacrifices on behalf of each other. So, and when Chris and I were talking earlier, sometimes that's luck, okay, to meet that person at the right time. But there are other characteristics, ones that, for example, Magdalena, perseverance, as Chris and I talked about, luck. But the other one that I think is going to be a driver for success is curiosity. That's professional curiosity, that's personal curiosity. Where is my relationship with this person going to take me next year? And you reminded me of something when you commented just a minute ago, when you talked about the challenges you're facing. Well, I got news for you. If you were to set yourself a goal every year and say, I'm starting over again, you're going to have a successful life, because you're going to accept the challenge of the next coming year. the recriminations of last year, a lot of things you can't fix, but you can start over. And it doesn't have to be a new job or a new location or a new country. It can just be my thinking, the way I'm thinking now. How do you think McIntyre got where he did? You think that he ever stops thinking? I mean, look at the guy. He never stops thinking. And it's curiosity. Are you curious, Chris? I'll bet you're curious.
Constantly.
Absolutely.
What happens if I put my hand in that leaf blower?
Well, I'm going to advise you against that. But that's my point, is there'll be drivers for your life. And I just would urge all the youngsters in the audience, curiosity is going to be the mainstay. If you remain curious, whether that's in personal relationships, in professional life, that is going to be a very powerful shaping characteristic.
Thank you. Dr. Daugirdas, I have a tiny question. A lot of the young nephrologists or the younger generation admire, well, you're the panelist. Who do you admire? Who is the person, or what keeps you motivated?
Is this for me?
No, for Dr. Daugirdas.
Oh. Well, first of all, I admire the person that talked me into nephrology. He was Dr. Todd Ng. Maybe not a lot of people know of him. He's published many, many papers. I just like the way he's from Hong Kong, and a lot of those people also trained in the British system. And somehow, I think when he was in London or whatever, they have to take oral exams, so they're very well versed in medicine. But he was also always very. So first of all, talking about curiosity, he was extremely curious, and we actually wound up reporting on a number of interesting conditions in dialysis for the first time. I remember I was in the OR, and we reported the first patient with peritoneal sclerosis, and I was in the OR taking pictures for the article, which was published in Archives, and it was the very first time this was reported. I remember going on rounds. We saw patients with high peritoneal white counts, but they didn't appear to have peritonitis. And so this was peritoneal fluid eosinophilia. And so I think Dr. Ng would be always had this culture of curiosity in terms of patients, and also this desire to write them up. Even though we weren't Harvard, we weren't the UPenn, it was actually a relatively second or third tier program. But also, what made me admire him was the sort of the ethical concern for patients. We were at a VA hospital, and where sometimes patients get the short end of the stick, and in our program, even on weekends when we had weekend call, it was demanded that the attending physicians see all the patients on rounds and the veterans and families. And we had meetings where we would discuss every patient. So I thought that this was somebody that I really respected and continued to respect, and so that was my contribution.
And I'm gonna throw the gender card here. I don't know if Allison, for being a woman, for you think that being a woman has an impact on your career, has had an impact on your career? Does it make it more challenging or more difficult, or even balance your personal life and your work while you're a woman?
So I think personally, I wouldn't say that I've really faced substantial challenges because of being a woman, actually. So I've been in, a really fortunate or blessed position that I haven't had to really deal with those sorts of issues. All my close colleagues, my mentors, the people that I work with, all very respectful and also quite mindful of gender equity and those sorts of things. But I think Actually, there's one aspect, it's probably to do with imposter syndrome, and I think it's more common in women who feel this way. You kind of feel like you're sort of faking it all the time, and that, you know, someone's going to catch you out for not knowing anything. It's a kind of a strange sort of phenomenon, I think. It's probably more common, and I see it more commonly in women. And that's something that you just have to address and deal with. And the way I kind of overcome those sorts of feelings is I remember why I'm in it. So I remember that I'm doing this because I want to see improvements in patient care and in patient outcomes. So remaining focused on that, I sort of try and kind of overcome those sorts of insecurities and uncertainties.
And I have a question that I received from a lot of fellows here. All of you have something in common, with several things in common. One, you all teach, you like academia, and you all do research. So when you have fellows come in from other parts of the world that don't have probably the funds, the grants to do the high-level research or the research that is needed, how can we, or what would be your advice for those who are trying to do research, to trying to do better for their communities, to get those funds? What is the best way to get the funds, or to get the grants, or to get the collaboration needed for be able to do all these things? Because we cannot all move to the US, we cannot all like go to the places where money is, and we don't have money in a lot of places. So Dr. McIntyre, you have a stealing is not an option.
In my capacity as a repressed minority group, an Anglo-Saxon white middle-aged man, it's obviously been very hard for me to struggle through these years. It is a question of perseverance, and people try and get some money and something, and it doesn't come off, and they try again, it doesn't come off, so they say it can't be done. I wrote 17 grants before I got the first one. And I got the first one because I wrote 10 simultaneous project grants and delivered them in a pile of paper this high to the funding organization. So sometimes you have to carpet bomb your way into it. I think everybody has their own spirit animal when it comes to research. And some people, John, he's a mighty eagle. He soars above the academic world, swooping to take that which he wants. But my spirit animal is the lemming, the ability to hurl yourself over the same cliff again and again and again in a desperate search for money. So I think you do have to be really do have to persevere at it. I think you need to remain very focused in the clinical world, because that's where the curiosity is fueled by, and that's where you'll acquire the questions. And if you acquire a really good question, other people will be interested. And collaboration is built on a mutual interest in that question. So if you have that question, that's when you can start to talk to people who might be able to steer you through. And you try on the question, and you try it on again. And when you start doing that, it's a little bit like an 8-year-old girl walking around in mum's high heels and makeup and beaded necklace. You're aping it. You don't really understand the teeth of it, but that's fine. They'll help you through that. So if you can find the question, find the curiosity, that's where you can start to build the collaboration. And we often mistake consortia for collaborations. We make consortia all the time. That's how we get research projects done. And they deliver a project. A collaboration is when you find people who have a shared sense of vision with you and are mutually emotionally invested in your success. And when you find a collaboration, that's what you hang on to as tight as you possibly can. And you'll find opportunity will come from that. And I think you hear all our stories about how we've done things. You have to be flexible.
Yeah.
You can't make luck, but you can make sure that you're aware when you're being lucky, and then you follow with that. So I'd say try it on again and again and again, stick with curiosity, and find collaboration. Not just somebody who can say, I've got some data, do you want to analyze it? That's not a collaboration.
Okay. Yeah, and I think it's like not being afraid to reach out to people. Like sometimes we kind of feel like we're down here, and then we cannot ask that question, we cannot read, like send an email or, but I think it's the part of perseverance.
But of course, often you actually are down there, but everybody was at some point.
Yeah.
You know, to get up here, you have to work at it. So if you ask no questions, that's where you'll stay, because the system has no interest in elevating you if you don't wish to elevate yourself.
Exactly.
Regarding the mentorship, Dr. McIntyre, how do you think, what qualities make you a great mentor, and how will you deal with your failures and success of your mentees?
Well, I think that's collaboration. I think it is, we say these words, but if you don't celebrate your own success through the success of the people that you train, I think you're going to have a stunted life. I think all successful academic careers come in three parts. The first part is very much focused on your personal productivity. The second part is you're focused on the productivity of the people that you support. And the third part is when you move to the point where you might be supporting the mission of an institution, and then you're investing in the institution, whatever it is, the ISN or your university or your unit. So you have to make those transitions between those various elements, and the success of the people that you've trained are the propellant that take you between those different areas. And I find enormous satisfaction and genuinely want to be eclipsed by the people that I train. You know, the proudest thing I own is the list of theses that I've got on the shelf. I've supervised 39 PhDs now.
Wow.
And that's one of the few things I'll brag about.
And you will hear that collaboration is a thing. So there's the emails of everyone here in the panel. They have your emails and the program in the app. So if you have that question, if you have that curiosity, you can reach out to them, and maybe a collaboration will also start with some of them, not just them, like a lot of the amazing partners and coworkers and colleagues that we have around here. And it's just about trying and persevering, I guess.
And there is a question from the audience. How do you think you differ from your respective mentors? Anyone can answer. I think it's a general question.
Well, my mentor was Bill Bennett, who I still think the world of, just like John does with Todd Ing. And I differed from Bill in the sense that he wanted to excel in everything there was in nephrology, and I recognized my limitations earlier and realized that I would focus on one area, which was dialysis. And I think that's important. As we talked earlier about curiosity, another feature that is needed, particularly for people who are trying to, say, get training, coming from abroad, for example, to get training, demonstrate a passion. Now, that passion could be, oh, I have a passion to succeed. I'm sorry, that doesn't differentiate you from anybody else. But I have a passion to understand physiology. And then when we get such applications, we can steer it the right way. So if Bill had a passion towards transplant, and I had a passion towards dialysis, and we both had curiosity, then we both have a pathway towards potential success. And so I think a characteristic that you have to demonstrate is passion. And it can't be, oh, I just have a passion to succeed, because so does the world, okay? But I have a passion for this area, and I can envision this as a possible pathway. Can you help me get to that pathway? And then we can perhaps steer you in a constructive direction.
How do you, we keep talking about successful careers and failures, but how do you define, Dr. Madero, how do you define success?
I think success is doing what you love. And, you know, feeling gratified with what you do every day, and making a living of what you love. I think that's a success. And it's a very difficult question, actually, because success. How do you measure success? I mean, somebody once told me, right, when you hit having 100 publications, then you're successful. And I thought that was completely useless, right? Because, then you want something more. So, you need to be satisfied with what you do every day. And, I think that's, to me, a success is having a life that's balanced between what I love to do in my professional life and my personal life. And I think that's the hardest, right? Trying to find that balance. But I think if you find that balance and you can actually, enjoy the time you spend with your family without being guilty, and enjoy the time you spend in the hospital without feeling guilty, then, you have succeeded in a way, right? How do you do that? It's hard. I take it one day at a time, like alcoholics do, only for 24 hours, and then we'll move to the next day. Exactly. And I've said so many times, I said, I need a wife, and this is what I really need, not a husband. But anyway, mine has been supportive so far, but yeah, you have to, as a woman, I think you have to divide yourself among 1,000 pieces.
Do you think that on a women's side, it's more difficult to balance the personal life because we are often sometimes, and my family and a lot of my friends is like, when are you going to keep going? Are you going to keep, like, I'm a PhD student right now, and then like, oh, you keep going. Like, are you planning to get married, have kids, and all this stuff? Because as a woman, it's a little bit more pressure, and more in my country. So and that's why sometimes, how do you cope with that? How you balance? I think that's the tricky part to, and it comes to, everyone mentioned it, I think comes to goals, like setting expectations of what you want, what you define yourself as being successful. It's different for everyone, and it will be different for each person, maybe, and that is what keeps us going, I guess. How do we define those goals? Dr. Daugirdas, do you have any regrets on your career?
Well, no, I kind of regret that I didn't wind up at one of these super top-tier schools. And I think it was partly because of all this career changing and whatever. And I kind of wonder if it would have been different. Maybe it would have been worse, would have been better. But I always was interested to know if it would have been any different. I think I've been very fortunate. I mean, this winding up at the VA really was a good thing for me, because the Veterans Affairs had very strong programs to foster research and to allow people clinical time off. They had this research associate program, which I was part of, that funds your clinical time to go and to do research. And then for a number of years, I was associate chief of staff for research at the VA, which also then is an administrative function where you're developing research programs, but it takes you out of the clinical responsibility of generating money. So I think in retrospect, it turned out very well for me that I was where I was. So I don't really have those regrets.
Can people see, this is an audience question, can people see research as a remedy to burnout from clinical duties, or vice versa?
Say that again?
Can they view research as a timeout from clinical burnout? And vice versa, if you are burnout in research, you think stepping into clinical duties will rejuvenate yourself?
I don't know about the burnout. I mean, ideally you would like to do both. I think the reality is many academic programs now are having problems finding fellows in the US. So they're understaffed. So they get fellows and they need somebody to do the clinical work. So in the past, when they were full of fellows and had extra people, it was easier to give fellows more time off to do research. And so I think a lot of it, and this may be different in different countries, in Canada and sort of Mexico, but so I think a lot of the support for research depends upon the government and how the economy is set up and the values people place. Right now, at a medical school, you want to do research, you have to get a grant, get an NIH grant, get a training grant, get part of your salary supported, and that justifies you then not generating income for the university. And the other thing is, of course, if you have an NIH grant, then through indirect costs, you support the university and the division and the department. So, so I think those are the realities in terms of doing. I do think that it's a mistake. I mean, there's all kinds of research. I mean, a lot of it is to doing molecular biology. And I was never into that molecular biology aspect. I always thought it was very difficult to be good at molecular biology techniques and spend time in a wet lab and then see patients. I mean, because they're so disparate, they're almost completely different. Now, if you're doing clinical research or physiology research or even like health outcomes research, it's different. Then you're seeing patients, you have an idea about how a patient care can be better. But in the past, what was valued at universities was wet lab research and bench research because that's where the NIH money was. And so the university didn't care that if you published some great paper about making healthcare better, as if there was no funding and no indirect costs for the university. Now the VA sort of was a buffer against that and had an extra dimension and ability to survive and use time and to do research, and I think that really helped me. But I'm not sure about burnout. I think burnout may be a separate question. I don't think if you're burned out from clinical care that the correct way to go about this is to do research or vice versa. I never thought of it in those terms.
And how you think the young people growing up in careers should work against this burnout? How to prevent this burnout to happen?
Yeah. Well, I think it's difficult. I mean, I think you have to, and I think it depends also what Magdalena said about success. I mean, it's a balance of family time and professional time, and also your engagement with your community in terms of your feeling valued. Not everybody is fortunate to have a family. That many people are single, but then they can still engage with their community and in sort of broader societal function that gives them meaning and help. And I think it's very important to keep that part of your life going and not to completely bury yourself to the exclusion of all else in either your research or yourself. I mean, I think that's what leads to burnout.
I think John's completely right there. It's what is burnout? I think it is the sensation we have when our lives are out of balance. That's all that is. When you're raising young children, it's not how hard you're working. If you've got a decent night's sleep, it's all still fine. You can do everything. You're balanced. You're not burnt out from that. So I think it's the realization that you need to have that however important you think your careers are, etc., there's nothing more important than the people you have at home. People you love, your families, nothing is more important than that. And if at any point you find that you're sacrificing that for the other thing, for any protracted period of time, ask yourself some really, really hard questions. And sometimes you have to be a bit ruthless about creating boundaries in your life as well, to keep things compartmentalized, to allow them to not encroach and invade other parts. I never work at home, ever. I might go in early, I might come back late, but I never, ever write a paper or review a paper at home. That's just a boundary I created so I could contain it and try and stop it leaching over and causing that imbalance and that lack of control and the anxiety that comes from that. I think that's what burnout is.
And I don't know, like, I think sometimes it's normal because we're humans to get a sense of I'm done, like I'm tired, I'm like, but that doesn't mean that we don't love what we're doing or we don't. I think it's allowed to say at one point I need some time to readjust. And because I don't know if you ever feel like that your career has like on a stable or like monotonous type of hill. There's no more ups and downs. And then, did you ever feel like that?
Are you talking to me?
Allison.
Are you talking to me?
Talking to you.
Oh, does it go up and down?
Yeah.
I think I would say so. Yes, I don't think it ever kind of feels stable, especially because of the uncertainty of the funding situation. And with fellowships and things, I've had failures and both failures and successes, even still to this day. But I guess just going back to your other question, related to that, I think one of the biggest challenges for me, and I still struggle with it, is learning how to say no. And when you're kind of starting out, when you're young, it's really hard to say no to all the opportunities that might come at you. But then it can I guess cause burnout, or it makes it very difficult to juggle and manage. So set yourself a framework by which you can kind of filter through, requests and opportunities that come through, filter it through that framework, and so that you can take a stance and keep things manageable and keep your sanity, I guess.
I think that an antidote for burnout is satisfaction. And I'll give you several examples of that. For what Chris does, that satisfaction could be a scientific breakthrough or a grant that hits. That's satisfaction. For a clinician, that satisfaction could be one of your staff saying, "Oh, now I get it. I understand what you're trying to do." Or a patient saying, "Yeah, that works for me." So, and it comes back to the passion that I talked about. We all want to be happy when we go home, whether it's a separation like Chris just described or not, doesn't matter. You want to be happy when you go home. And when you're happy when you go home, I think you can stay at it longer. And I think the key to being happy when you go home is to have some success before you go home. And that success can be defined 100 different ways. The challenge for you is to find out what that is. Now, I happen to have the best job in the world because I have junior doctors who can say, "Now I get it." I have a staff that love what they're doing who now can say, "Oh, gee, I get it." And I have patients that say, I never wanted to do that, and now I see what you want. And they can't take that away from me. Now, the challenge to me is to find how to make that work. But I can, and that's the thing. That's our job, is to find out how you can go home happy. And I claim that you can go home happy by having your passion give you something positive.
Okay. I think we'll have more audience questions.
Yes. So this is regarding the fellowship match results. In light of recent fellowship match results, how is field of nephrology being viewed worldwide, not in the US alone? And how do you feel it has changed, and how we can start to approach this non-filling of fellowship issues again?
Yeah, I mean, the ASN, of course, has been very concerned about this, and it's in the literature, why nephrology is less attractive now than before. And I know the programs in Chicago have been having trouble attracting good fellows, and frankly, many of the fellows are not interested in research, just want to do clinical care. I think part of it is lifestyle and part of it is financial, I suppose. I mean, in terms of not having procedures where you can maybe make less money involved. Maybe some of it is lack of entrepreneurial opportunities to establish your own dialysis unit now that the dialysis units are primarily controlled by large dialysis organizations. I think some of it may be the excessive protocolization of a lot of what we do, so that you have less opportunity to sort of think and be creative with your patients, because everything is protocolized. So I mean, I find it remarkable because nephrology is still so interesting. It has all these different dimensions, and you can go in so many different ways. You can go into transplant, you can go into stone disease, you can go into treating hypertension and diabetes and CKD and dialysis. So I don't have an answer for you, frankly. I don't know, maybe Tom, you thought about.
Well, I don't agree with you at all, John. I'll be frank with you. I think that right now, a lot of the kids who are in their internal medicine residency want a handout. And I don't think they want to work as hard as nephrologists. And I think they see that the nephrology fellows are there at 5 in the morning, and unless we make them go home, they're going to violate their work hours. And it's because we love what we do, the challenge of a sick patient and how can I make that patient better. And I think that there are a lot of people in that generation that aren't interested in working that hard. And I hate to be so blunt about it. And that may be part of the reason that some of the best fellows we have been trained outside our country. They're hungry. They're hungry to do research. They're hungry to take care of people. And I think there's an awful lot of complacency. I don't know whether you guys are aware of it, but around 2013, the request for psychiatric help in American colleges went through the roof. Now, gee, is there something in the drinking water that did this? I don't think so. Okay, and there's lots of evidence that this is a systematic issue. Safe zones. We got to have safe zones. We can't talk about disagreeing. Yeah, we can. We can talk about disagreeing. And in nephrology, we do it all the time. We have to disagree with the surgeons all the time. And so I think it's a sign of the times. I don't think it's about money. I think it is about lifestyle, but I don't think it's about money.
So one of the audience question, as nephrology fellow came to US from a non-ACGM accredited country, I have a difficult time being accepted in residency program to be eligible for nephrology boards. What options do I have in order to continue my career as a nephrologist in US?
Go to Canada.
Go to Canada. Come to Mexico.
Screw the US.
I think Canada is it's not as easy. It's also difficult to. Yeah, it's not as simple. Just I'll go and then they'll give me.
But at least we'll be nice to you while you're in.
Oh yeah, because yeah.
So are these places where these people are coming from don't need nephrologists? I'm not sure I understand that. So there's such an excess of nephrology in some of these countries that, or is there some other problem?
I think it's a personal choice to stay in US.
Yes.
Oh, so they trained here and want to stay here.
Yeah, they didn't do internal medicine residency here, but they are trained in nephrology. Since they don't have internal medicine residency, they are not eligible for boards.
Well, I can tell you the most recent ones that have trained with us have gone on to serve in underserved areas. I can give you a couple that are so popular in those underserved areas that once they completed that, they wanted to stay. The community wanted them to stay. So I don't know all the details of whether that's still happening, but you want to go to the upper left corner of Mississippi and think that they don't need nephrologists there? Yeah, they do. So I think there are ways to do that. I don't know the politics of it anymore. I don't know if it's as easy as it was because it isn't what I do. But I can tell you we don't have any trouble with that in our program. Our program fills, and we don't have any. If you come out of the Vanderbilt program, you get the cream of the choices of jobs. So I don't see that. So I perhaps should not comment any further.
And then I think everyone has mentioned because it's about being successful, but also what makes you happy. And then if being a nephrologist or being a researcher, whatever makes you going. Like we need nephrologists in Mexico, in Chile, in Brazil. Like there's kidney disease all over the world, Canada. Germany, the Netherlands, basically, I think in Mexico it's a little bit different. There's more fellows who want to do nephrology. They keep opening places to do residency. I don't know how it's in Canada. Here, I know there's a lack of positions being filled, but it's just one. We're talking about just one part of the world that we have a whole world that needs kidney care. There's patients everywhere, and we need to focus on that. I will say that there's opportunities everywhere. You're just not knocking that doors and asking the right questions.
I think if whatever you're doing it well, and you're good. I know this sounds really banal, but I can't think of anyone who was really good. You know, they were productive when they needed to be, they were caring when they needed to be, they were impressed with their clinical skills. I don't remember anybody who didn't do okay in the end. Good people will always find places. The challenge now is the program is not designed to guarantee mediocrity through it. And particularly if you're trying to change systems, that's going to be difficult unless you are demonstrably good. You have to generate value in yourself that can be appreciated externally. I think your comment about the letters of support is very right. People often don't give a monkeys about someone else's opinion. But if this is a series of evidence-based successes to show that you're an evolved, developed person, things will probably open up. It's a very unsatisfactory answer because it suggests that so much of our training and progression is actually haphazard and isn't part of a genius master plan you hatched the first day of medical school. But that's life, you know, just get with it. That's what's going to happen.
So we're about to finish, and I want to close this discussion by asking one of each of you to give an advice that you would like to, when you were at that moment, a thing that you would like to hear of the younger version of you that you can give to all the young nephrologists, researchers, and everyone who's here. We'll start from that to here. Dr.
I'll reiterate what I said before. Define what you're passionate about and chase your passion.
Yep, be grounded in your values, whether that's, family first, integrity, excellence. Know your passion, pursue your passion, and persevere.
Advice I got on the first day of medical school by my original dean, who was like a small, poisonous Jewish Yoda. He was an appalling human being who believed that we were all scum in some way. And he had his first words, and then I ran a medical school before I left the UK, and I had to give that first lecture first day, and I found myself coming back to it. And he said, I want you to go home and stand in front of the mirror and practice saying the words, everything will be okay, I am here. He said, because when you're sat on call in the middle of the night in some shithole hospital, you can't get the patient into ICU, there's nobody else there, you have got absolutely nothing else. But the patient will not need anything else from you at that point. And the confidence and the competence within you will make that convincing. So I would say if you're interested in research, focus on your clinical work. Find the grounding there and take the power and the energy and the curiosity from that. Don't separate it. It's not an antidote to some terrible drudgery. It's all one thing.
So I think my advice would be, if you have a passion, never lose the enthusiasm, because you have to have a thick skin, especially if you're going to do research. You're going to get bitten so many times. So, this phrase I love, it's success is the capacity to go from one failure to the next without losing the enthusiasm. So you just have to be persuasive.
My advice is just more in the research area. So first of all it's very important that you pick a topic that's clinically important. So when I started out, I got very interested in acetate because everybody was using acetate dialysis. So I did all these studies with rat tail arteries, with why I was interested in why acetate was a vasodilator. And we looked at cyclic AMP, intracellular pH, we looked at calcium fluxes, and did all these hemodynamic studies with acetate, maybe 20 papers. And nobody cared, because everybody switched to bicarb, and then nobody then cared and cared now. So one of the great things that Chris has done now is he really was able to focus on an area that people care about, which is ultrafiltration and stunning and damage. But that's very important, is first of all, because you're going to be spending a lot of time on your chosen area of research. So first of all, make sure it's important. And the second is, it's very good in research for people to know who you are. I know a lot of people who have published 300 papers, but they published a little bit here, a little bit there, a little bit there, and then nobody knows, even though they have all these papers, what they did, what they're known for. And so they don't get invited to meetings, they don't go with this. So it's almost good to develop an area so that when people say, well, I want to know about stunning, I want to know about hypotension, I'm going to call Chris, or in my case, if they want to know about adequacy or a little bit about IDH as well, they come to me. So I think it's very, very important not to go from one to another. Now, of course, you can have a plan B, because sometimes one thing doesn't pan out and something else does. Like, I did this one evening I spent with this equation, this KT/V thing, and that everybody talks about that, and that's what I'm known for. I spent years doing other stuff, papers published in JCI, AJP, looking at rat tail artery dissections, kind of what Chris is doing, and they're never cited. Nobody ever cares about them. So somehow, it is partly luck, but I think it's, some people are luckier than others, maybe because they have more common sense than others. So before you spend a lot of time in terms of research activities, take a global look back, make sure that the research question you're asking is important.
Okay. Well, thank you so much for sharing your experiences with us. Thank you, Raja, for the questions. And thank you all for staying that late. So enjoy, I guess it's already dark LA. And have a nice dinner, everyone. And thank you.